Greetings, this is Miss Gibson. This is your lecture 2 for cancer. It is going to be going over cancer treatments as well as medications. Cancer, while it's considered a chronic illness, has thousands that live 5 years or longer, while 68% are cured. Now, they may have exacerbations or remissions throughout life, regardless of the treatment, but cancer still has a negative impact on physical and psychological functioning and quality of life. Not only as nurses are we taking care of the patient, but we also want to make sure that we're providing good education and support to the caregiver as well. Consequences of cancer, we have impaired immunity and clotting. When cancer starts invading bone marrow, which is where blood cells are formed, this results in reduced production and function of healthy white blood cells. Leukemia increases risk for infection. Some treatments, especially chemotherapy, reduces neutrophils, which makes the patient more prone to infection. Bone marrow invasion by cancer cells results in anemia, which is decreased red blood cells, and thrombocytopenia, which is reduced platelets, resulting in impaired clotting. Some signs and symptoms of anemia would be fatigue, tachycardia, and shortness of breath. We have altered GI functioning. Tumors in the GI tract increase metabolic rate and nutritional needs from disease treatment and treatment-related appetite loss. They could also have loss of taste, resulting in weight loss. Cachexia, which is extreme body wasting or malnutrition. This is because breaking down of, the cachexia is because increased catabolism, which is breaking down of molecules. This is just from where they have an inadequate intake of nutrition. They kind of look like they might be anorexic. There's not a whole lot of, they don't have a whole lot of fat on them. Very skinny, you can see their bones, is what that would look like. They should be encouraged to have small, frequent meals, supplements between meals. They should be encouraged to eat a healthy diet with complex carbohydrates, fiber, and protein. They may need enteral feedings. And you definitely want to make sure that there's a registered dietitian on board as part of that healthcare team. Abdominal tumors may obstruct or compress the GI tract, resulting in decreased absorption of nutrients and or elimination of waste. Liver invasion by tumors leads to malnutrition and death. There could also be altered peripheral nerve function. This could be from tumors in the spine. More common cause is the chemotherapy, if they have to go through the chemotherapy. Neurotoxic chemotherapy agents injure peripheral nerves, leading to peripheral neuropathy with decreased sensory perception. Then you have CIPN, which is chemotherapy-induced peripheral neuropathy. This is loss of sensation, especially in the lower extremities, with numbness, tingling, neuropathic pain, change in gait or balance could also occur. Those with pre-existing diabetes mellitus or AIDS have an increased chance of developing this chemotherapy-induced peripheral neuropathy. Then you have motor and sensory deficits. This is because the perception deficits occur when invasion of bone, brain, or on nerves compress. When there is compression on the bone, the brain, or nerves, causes motor and sensory deficits. In regards to the bones, if there is a metastasis, that's usually from lung, breast, or prostate. The bones become very thin, which increases the risk of fracture. If they do have bone mets, this is very painful. They, of course, have an increased risk for fracture. They could have spinal cord compression, hypercalcemia, and decreased mobility. Their sensory perception will change due to the spinal cord damage or the nerve compression. Brain tumor, whether it's malignant or benign, destroys healthy tissue, and can lead to death if that is not treated. Then we also have cancer pain. This does not always accompany cancer. There are some cancers that may not be painful. Can be a major problem if it is chronic pain. There has to be a intra-professional approach. You want oncologists, certified nurse oncologist. There could be pain management would be on board as well. You also want to provide good patient education on side effects of pain medicine, such as constipation. And then last but not least is altered respiratory and cardiac function. Cancer can disrupt respiratory function, capacity, as well as gas exchange, leading to death. So in regards to airway, if you have an airway tumor, it could result in obstruction. If there's lung tissue involvement, the capacity decreases, leading to hypoxemia or dyspnea. The cancer cells thicken alveolar membrane and they can damage blood vessels. Both of that results in impaired gas exchange. The tumors can also press on blood vessels as well as lymph nodes in the chest, which can compress the airway, which could lead to dyspnea. You could also have superior vena cava syndrome. This is an oncology emergency. The great vessel, which is the superior vena cava, is compressed, which could lead to death if that is not treated immediately. And then with the cardiac function, both radiation as well as some chemotherapy treatments can affect cardiac function. Even with shielding, cardiac events can occur at younger age related to even with shielding, cardiac events can occur at a younger age. Pericarditis, myocardial dysfunction, valvular heart disease can all increase the risk of impaired cardiac function. The risk does increase with pre-existing risk factors such as hypertension, smoking, even high cholesterol can increase that risk. Chemotherapy does contribute to cardiac dysfunction. There's a loss of myocardial muscle leading to heart failure. Sometimes that can be reversible, but it could become permanent as well. Cancer management surgeries. Cancer management, the purpose is cure or control the disease while minimizing side effects of therapy. An example of this would be leukemia. Failure to treat would result in death within weeks or months. May use single or combination therapies based on type of cancer. Not only on type of cancer, but has it spread, the patient's overall health, the status of the patient. Most types of cancer have established protocols for surgical interventions. And then, as far as surgery goes, it could be for prophylaxis. They would remove potentially cancerous tissue to prevent cancer development. Pre-malignant condition or strong disposition for development of specific cancers, such as removing a colon polyp. Then you have diagnostic. This is an excision biopsy, is an example of the diagnostic. This would remove all or part of the suspected lesion for examination, as well as testing to confirm or rule out a cancer diagnosis. The surgery could also be curative, which removes all cancer tissues. This is the most effective if the tumor is small, non-invasive skin cancer. Basal cell skin cancer would be one example of that. Then we also have cancer control or the cytoreductive surgery. This removes part of, but not all of a tumor. It's a debulking is what the book refers to it is. Decreases the size, number of cells. It will alleviate symptoms and enhances other treatments. It can increase the patient's survival time. Then you have palliative surgery. This is for symptom relief. It increases quality of life, but it's not a cure. It removes tissue that causes pain, obstruction, difficulty swallowing. It could also be treatment for neuropathic pain from bone metastasis. Then last, you have reconstructive or rehabilitative surgery. This is going to be to increase function or enhances appearance of both. It could increase function or enhance appearance or both. Examples would be breast, esophageal reconstruction, bowel reconstruction, cosmetic head and neck reconstruction from throat cancer. Side effects would be loss of body part or function to ensure cancer removal, scarring, disfigurement, profound changes in appearance or activity level, could lead to depression, grief, or decreased enjoyment of life. And then for post-op care, you're going to provide that psychosocial support. You're also going to provide that caregiver support that we talked about at the very beginning. Surgery rapidly following a diagnosis may be a barrier to coping. You want to encourage patient family questions, give them an opportunity to express concerns. You're also going to have time to educate them on signs and symptoms of infection, what to look for at the surgical site. You could also provide referrals to support groups. They may actually have to go to rehab. Most of your nursing education is going to revolve around mobility, pain management, infection prevention, that type of thing. All right, next is for cancer management, we're going to discuss radiation. You have teletherapy and then brachytherapy or brachytherapy. Radiation therapy, also known as radiotherapy, this is high energy radiation from gamma rays or ionizing radiation beams to kill cancer cells. This provides disease control and relief of symptoms. With your radiation therapy, there's minimum damage to surrounding tissues, minimum hair loss, minimum skin changes occur to the local site. Newer methods have precise delivery of higher doses and spare the surrounding tissues. Cells damaged by radiation either die outright or become unable to divide. Dose depends on tumor size, location, and sensitivity of tumor in nearby tissue. The breast does tolerate a higher dose than the liver, which is just one example. It's usually given in a series of divided doses, usually daily. Can be used alone or with chemo or immunotherapy. The radiation delivery methods, there's an external beam, which is the teletherapy. This is delivered by a source outside the patient. Thus, patient is not radioactive and no harm to others. It does require knowledge of exact tumor location. Requires patient to be in exact same position for all treatments. So you would have to ensure your patient was physically able to get into that position and maintain that position. For that type of radiation, they would also use tattoos to mark the area where that they would know where to direct the beam at for every treatment. Then you have internal device or the brachytherapy, or this depends on the type, size, tumor location, and the patient's general health. Radiation has direct, continuous contact with the tumor for a specific time. Radioactive isotopes, either in solid form or within body fluids. The radioactive source within the patient emits radiation for a period of time and can be a potential hazard to others. So the teletherapy, that is the external beam. You would need to know where the tumor was located. And then the internal device, or that brachytherapy, is where it is emitted internally. The isotopes that are unsealed or suspended in fluids enter the body fluids and are excreted in waste. Therefore, waste are radioactive and should not be touched. This is seen a lot in thyroid cancer, where they will inject something into the thyroid, or the patient will have to ingest a capsule that has radiation in it. Solid or sealed sources, these are implanted within or near the tumor, can be temporary or permanent. They do emit continuous low energy radiation, but excreted waste are not radioactive. One example would be for patients with prostate cancer, they can inject seeds that are permanently placed within the prostate. Some side effects vary according to site. There could be some skin changes, could be hair loss locally. Often it's not permanent hair loss. Altered taste sensations, could have some aversions to red meat, fatigue, bone marrow suppression. There could be some damage to normal tissue, causing inflammatory response that lead to tissue fibrosis as well as scarring. And then your patient care or patient education would be skin care, mouth care, treating them for dry mouth, encourage them to go for regular dental visits, and then they could also have weakened bones depending on where their radiation was given, so they would be at an increased risk for pathological fractures. So that's all education that you want to provide to the patient. The next management topic is chemotherapy. So, cytotoxic system therapy. These are drugs used to kill cancer cells or disrupt cellular regulation. Used when cancer has spread beyond a localized area that can be removed with surgery or treated with radiation. Unlike other therapies, kills cancer cells as well as normal cells throughout the body. Chemotherapy, it's a treatment of cancer with chemical agents used to cure and to increase survival times. Does have some selectivity for killing cancer cells over normal cells. It is more cytotoxic to cells that divide rapidly, such as skin, hair, as well as your blood-forming cells. Tumors with rapid growth are often more sensitive to chemotherapy. Chemotherapy is useful for metastatic cancers since it is systematic. So some of your drug categories, you have alkylating agents. These are cross-linked DNA, making it bind together. Prevents proper DNA and RNA synthesis, which inhibits cell division. Some side effects of your alkylating agents is infertility, nephrotoxicity, and hemorrhagic cystitis. Your anti-metabolites, these fool cancer cells into using them in cellular reactions because they do not function as normal metabolites. It impairs cell division. Side effects would be nausea, vomiting, alopecia, and leukopenia. Your antibiotic agents, they interfere with action of mitosis. The cancer cells cannot divide, or they only divide once. Some side effects would be depression of deep tendon reflexes, motor weakness, cranial nerve disruption. Your anti-tumor antibiotics, they damage the cell's DNA and interrupt DNA as well as RNA synthesis. I can't even say it. Forgive me. Next, you have the topomers. This disrupts the enzyme essential for DNA synthesis as well as cell division, leading to DNA breakage and cell death. Miscellaneous refers to chemotherapy drugs with mechanisms of action that are either unknown or do not fit another category. And then a combination chemotherapy, this is given more than one drug in a timed manner, may be more effective yet increases side effects. Some treatment issues could be drug selection based on sensitivity of cancer cells, stage, the extent of the disease, could be dosage calculations. Patient and family education is critical. Generally, it's given via IV. Sometimes it can be intrathecal, which is spinal cord injections. Interventricular, which is given through the brain ventricles. Intraperitoneal, given through the abdominal cavity. Intra-arterial can be given through an artery to the liver. If you are giving it through the IV, you would need special training on the chemotherapy. There's a certificate that you would need to get for that. So any IV complications, it requires special handling and training. Nurse should wear PPE and chemo gloves. We do need to understand that the oral chemotherapy medications are just as toxic and should be handled with care, just like the IV chemotherapy drugs. Side effects of chemotherapy, so you have bone marrow suppression, which can cause anemia due to decreased numbers of red blood cells and hemoglobin. They'll complain of fatigue and hypoxia. Neutropenia, this is decreased number of white blood cells, leads to immunosuppression. This puts them at a high risk of infection. Thrombocytopenia is a decreased number of platelets, high risk for injury. It impairs clotting and bleeding. Chemotherapy-induced nausea and vomiting. Many of the drugs are vomit-inducing, so you would treat with an antiemetic before chemo. They may also be given antiemetic drugs on a routine basis and as needed. Mucositis is sores in the mucous membrane, especially in the mouth. Stomatitis involves other tissues in the oral cavity. You'll see them have open sores that almost look like ulcers, especially around the lip, inside of their lips. You want to promote good oral hygiene. Encourage them to use a soft bristle toothbrush. You want to rinse with water or saline and no alcohol-based mouthwash. Alopecia, which is just hair loss, usually is temporary. New hair could change color, thickness, or texture. You want to encourage them to protect their scalp from the weather, the elements, sun, cold, that kind of thing. They could have some changes in cognitive function, such as a reduced ability to concentrate, memory loss, difficulty learning new information. So you want to provide good psychosocial support. And then the last is the chemotherapy-induced peripheral neuropathy. This is loss of sensory or motor function of peripheral nerves. So they could have a loss of sensation in hands and feet, orthostatic hypotension, erectile dysfunction, as well as pain from the chemotherapy-induced peripheral neuropathy. And then, last but not least, we're going to talk about some oncologic emergencies. This DIC, this is condition where organisms enter the bloodstream. It puts them at let me back up. Sepsis is a condition where organisms enter the bloodstream and can result in septic shock. This is due to low white blood cell counts and an impaired immune function. The disseminated intravascular coagulation, or DIC, this is a problem with blood clotting. The blood clotting process causes extensive bleeding from many sites, decreasing blood flow to organs. Prevention is key. You want to identify the patients at risk. Treatment is usually with heparin. Treatment for sepsis, of course, would be antibiotics. Next, you have a syndrome of inappropriate antidiuretic hormone. This is in the body induces antidiuretic hormone secretion from the posterior pituitary. When not needed by the body, water is reabsorbed in excess by the kidneys and put into systematic circulation. Retained water dilutes blood sodium levels. It causes weakness, muscle cramps, loss of appetite, fatigue. Treatment, you're going to treat the cause, focus on safety, restore fluid balance, prevent fluid overload. Then you have spinal cord compression. This is damage that occurs either when a tumor directly enters the spinal cord or column, or when the vertebrae collapse from a tumor of the bone. You're going to assess for neurologic changes, back pain, muscle weakness, sensation of heaviness in the arms or legs, numbness or tingling in hands and feet, inability to distinguish hot and cold. They may also have an unsteady gait. Treatment is palliative with corticoid steroids, radiation to reduce the size of the tumor, or surgery to remove the tumor. A medicine that might be given for the syndrome of inappropriate antidiuretic hormone would be D-meclocycline. This works opposite to ADH. So that is a medicine that you might see given, and it does discuss it as well in your textbook. Next, we have hypercalcemia. This is increased serum calcium levels. High levels are an emergency and can lead to death. Some symptoms might be skeletal pain. They could have kidney stones, abdominal discomfort, altered cognition, fatigue, loss of appetite, nausea, vomiting, dehydration. They may also have ECG changes. The treatment for that is going to be oral hydration, loop diuretics to promote calcium loss in urine. They may also be given calcitonin, oral glucocorticoids, or they may also be given dialysis. Superior vena cava syndrome. This is compression or obstruction of the superior vena cava. The superior vena cava returns blood from the cranial neck, and upper extremity vascular to the heart. Tumor growth or clots in this vessel leads to congestion of blood. Early symptoms might be edema of the face or eyes, tightness of shirt or blouse, engorged blood vessels, erythema of upper body, edema in arms and hands, dyspnea, or nosebleeds. Late signs and symptoms would be hemorrhage, cyanosis, mental status change, decreased cardiac output, hypotension, or death. Treatment is high doses of radiation. They may be given chemotherapy. They could remove the tumor that is causing the compression or stent placement in your superior vena cava. Last, we have tumor lysis syndrome. This is where large numbers of tumor cells are destroyed rapidly. Their intercellular contents, including potassium and purines, enter the bloodstream faster than the body can eliminate them. Severe or untreated tumor lysis syndrome can cause tissue damage, acute kidney failure, or death. We know that the hyperkalemia can cause cardiac dysfunction. The high purines form uric acid, and then hyperuricemia blocks kidney tubules. So the treatment would be, prevention is hydration of 3,000 to 5,000 mLs of fluid per day. Diuretics and drugs to promote purine excretion, which is allopurinol. If this is very severe, they could get dialysis as well. So that is the end of your cancer treatment and medication lecture. I know it is a lot. If you have any questions, feel free to email me. If I have misspoken or confused you, please email me. That's what I'm here for. Thank you and have a good day.